am Dr. Anjali Shetty, neurophysiotherapist. Firstly, I wanted to thank each one of you who have liked and commented on our previous video, The Art of History Taking. And for those of you who haven't seen, go back and have a look and get some tips and fundas that you can use for history taking, as history taking is extremely crucial and the starting point of any assessment. Our topic for today is assessment of higher mental function, which is generally the first part of any neurological assessment. Now, as physiotherapists, we do not spend more than 5 to 10 minutes in assessing higher mental function. But that is only possible if you knew the components of higher mental functions, and why as physiotherapists we must know them, we will understand in the video. We will go about in understanding the basic physiology and philosophy of different components of the HMF. And for your ease, we have divided the assessment in different parts so that we can understand each component in brief. In today's video, we will understand some basic information about the higher mental function and two of the components, that is assessment of consciousness and orientation. In the subsequent videos, we will understand some more components and some generally used scales that we use to assess the higher mental function. Now, I stated that generally HMF is the first part of a neurological examination. Now, you might wonder why, and the answer is simple. HMF gives you the status of the patient. Your entire following approach to examination and therapy is based on HMF. Say for example, your approach to further evaluate a patient who is cooperative, active, conscious will be different as compared to a patient who is drowsy, unconscious, very agitated, right? So this basically tells you how we should proceed with our examination. It gives you the status about their speech, about their memory, about their consciousness. So this is very, very important and hence done first. Now they say a good history leads to an appropriate evaluation and an appropriate therapy. And this is so true because a lot of information of the HMF can be picked up right from history taking if very keenly observed. For example, when a patient is giving you history, so much of information can be picked up right from their facial expressions, from their voice, from their behavior, from their attitude, their appearance, if they're very unkempt, untidy, or they're shaving only one half. And that says that you might need to do a little more of perceptual test as well. If they are giving you history or they need help of their caretaker and family, and is it because of memory issues that they can't remember, or is it because of the speech, then you know that you have to evaluate that as well. So much of information can be picked up, and you being the first part of the rehab team, okay, if you see that behavior is very extrinsic or you might need a detailed, assessment, then you might also refer to a psychologist and psychiatrist for further detail. Also during history, you might have come across this, that patient's family is telling that suddenly his behavior looks different. Suddenly, I think there are some memory issues post that trauma or injury. Okay. Very, very common after head injury patient, in head injury patients post-stroke. So it is very, very important when you hear such things that you might need a detailed HMF. And for that, you also have to know their pre-morbid status. Pre-morbid, that is before they were diagnosed, before they were had some trauma or stroke. How was their behavior? How was their memory? How was the speech? So then we can compare and find the difference and then evaluate it further. In today's video, we will understand two components, consciousness and orientation, a little bit about both, and here we go.
The first component is the assessment of consciousness. This is extremely important in an ICU and IPD setting. In an OPD setting, you will see patients more from a drowsy to more active patients. Now, what is consciousness? Consciousness is the capacity or ability of an individual to be aware and also to respond to body's own needs and to external environment. If a person can do so, he is said to be conscious. Let's just understand the neurophysiology behind consciousness. I've tried and kept it very basic and simple, not going in too much of detail. So this is a simple picture of a brain. This is your frontal lobe, parietal, occipital, temporal, your cerebellum, your brainstem, which will further continue as spinal cord. And for convenience sake, I have drawn the thalamus outside. Now the main area for your consciousness and awareness is your brainstem. And why so? Because all our sensory fibers, sensory inputs, get synapse in the brainstem, forming small reticular network of fibers, which we call as the reticular activating system. And these net-like structures, hence the name reticular, will further give inputs to different parts of the brain, thereby creating awareness and consciousness. Any injury to any part of this area will definitely have an effect on consciousness. But if you have a frontal lobe lesion, for example in stroke, you might not see too much effect on consciousness because all the other parts take over. But if you see a thalamus getting affected, thalamus is responsible for your sleep-wake cycle, which will definitely have an impact on consciousness. But if a brainstem, if you see in tumor or pontine hemorrhagic stroke, and we know that there are many cranial nerve nuclei also situated here. So any lesion here will definitely have an impact on the respiration and consciousness of a patient. So the most important is to know here is the reticular activating system and the brainstem, which is responsible for your consciousness. There are several ways of explaining the levels of consciousness. The first being alert, wherein the patient is awake, attentive, giving normal interaction. The second is lethargic. Patient is often drowsy and may fall asleep if not stimulated in some way. The patient has less focus, can be easily diverted from the task and questions. Hence, the therapist must make sure that the conversation with them is simple and loud. The third is obtunded. These patients are difficult to arouse from sleep, and even if you somehow arouse them, they often appear confused. Mostly any interaction with them tend to be non-productive. The next is stupor or semi-coma. These patients respond to strong, vigorous, painful stimuli and then go back to their unconscious state when stimulation is stopped. They are unable to do any voluntary reaction and may often give mass movement or reaction. The next is coma or deep coma. Here, the sleep-wake cycle is absent and patients' eyes are usually shut. They do not respond to painful stimuli and reflexes may or may not be present based on your site of brain injury. They are often ventilator dependent. The next is vegetative state. Here, the sleep-wake cycle is present but is irregular. And even if they are awake, they are not aware. If they continue to be in this state for more than 1 year in traumatic brain injury and more than 3 months in anoxic brain injury, they are called as persistent vegetative state. So the most commonest scale that we use to assess consciousness is the Glasgow Coma scale. So Glasgow Coma scale or GCS assesses the 3 areas: eye-opening, verbal response, motor response, each of which has different components which is added up and the score should be 15. If it's 15 then the patient is conscious. If it is 13 to 14 then there is mild level of injury. If it is 9 to 12 moderate, 3 to 8 indicates severe level of injury, and these are your comatose patients. 3 maximum would be 15. Let us just quickly understand all the 3 areas and its components. So the first is eye response. Before assessing the eye response, make sure that the patient is not fast asleep, otherwise your assessment would be mistaken. So the first is opening eye spontaneously. So when you look at the patient and he is opening and closing eyes, giving meaningful looks, then you score him 4. If the patient is not opening eyes spontaneously but opens to verbal commands, so you go to him and in loud clear voice you say, "Mr. Rajesh, wake up," and he opens his eyes, then you score him 3. If not by verbal command, then you elicit pain response, pinprick, pressure, pinch at the fingertips, earlobe, or supraorbital ridge. The supraorbital ridge are usually preferred because if finger has sensory issues, he would not appreciate pain. Even after which he doesn't respond, then you say no eye opening, 1. The next is verbal response. In the verbal response, there are 5 components. So the first component is oriented. If the patient is giving you meaningful conversation, is oriented to time, place, and person, then you score him 5. If the patient appears confused, is talking confused in a confused way, मैं कहाँ हूँ, किधर हूँ, आप कौन हो, then you score him 4. If he is using inappropriate words that doesn't have any meaning, then you score him 3. If he's grumbling, mumbling, making sounds, then you score him 2. No verbal response at all, you score him 1. The next is motor response. Motor response has 6 components. The first is obeying commands. If the patient is moving hand, gripping objects, making a fist on commands, then you would score him 6. If he's not moving, then you would elicit a pain response again, same area, supraorbital, fingers, or the earlobe. And if he's able to localize verbally or show it with your fingers where the pain is, then you score him 5. If he's not able to localize but still withdraws himself from the pain, then that's a normal reflex that you would see and you would score him as 4. And in a normal, you would see only an elbow flexion. But the same thing when he's withdrawing and you see an internal rotation, adduction, wrist finger. So there is an abnormal flexion response, then you score him 3. Similarly, in an abnormal pattern, if he's extending, you score him 2. No response at all is 1. So you would see motor response, no eye opening, no verbal response are 1, 1. Hence the minimum score is 3. But GCS has its own limitation. Like it does not take into account your pupillary and corneal reflex. What about the patients who are intubated, has tracheostomy? You cannot check the verbal response. If a patient has an eye swelling, facial fractures, then you cannot check the eye response also. So hence there were need for some better scales. So now if you're using GCS, it's mandate that you see the pupillary size and reaction to understand if there is any brainstem affection. So these are some good to know points. Okay, so if in unconscious patient, while you're examining the pupil, you see they are bilaterally small, this would indicate there is some damage to the sympathetic system in the hypothalamus or the metabolic encephalopathy. If the pupils are pinpoint bilaterally, then that would indicate a hemorrhagic pontine lesion or a narcotic overdose. Next, if there are large bilaterally fixed and dilated pupils, that indicates severe anoxia and drug toxicity. But if only one pupil is fixed and dilated, then that would indicate a temporal herniation compressing on the oculomotor nerve and a midbrain affection. So these are some quick pointers that would help you to reach your diagnosis. So friends, as we saw, there are some limitation in GCS. So here's another scale for us to explore. That's the 4 score, and the full form is full outline of unresponsiveness. As compared to GCS, this scale is much better in terms of sensitivity, specificity, reliability. It's a 16-point scale. तो हमने देखा था GCS we could not give it to intubated patients, we could not give it to paralyzed patients, and it did not include brainstem responses. So this scale fulfills all of that. Can be given in a locked-in patient, a vegetative patient. Each of these patients we can use this scale. So again, it has 4 areas: the eye response, the motor response. But the 2 more areas are the brainstem and respiration. So eye response is similar to GCS, and the beauty of this scale is that each of them has 5 components and are scored from 4 to 0. Okay. So again, in this scale, the lower the scale, the worse is the level of consciousness. So in eye response, the eyelids open and even track or blink on command. Unlike GCS, which only had to see spontaneous opening and closing. So यहाँ पे a lot of emphasis is given on tracking and blinking also. Hence, you can score them 4. If they are opening but not able to track, then you score them 3. If the eyelids are closed and open only to loud noise, then you give them 2. If they are opening to pain, then you score them 1. If they do not even open to pain, you score them 0. Coming to motor response, if the patient is able to make a thumbs up, a fist or a peace sign, then you score them 4. If they are able to localize pain when elicited with painful response, then you score them 3. If you see a flexion response, अब इसमें normal abnormal mention नहीं किया है, any kind of flexion response to pain is scored as 2, any kind of extension response to pain is scored as 1, and no response at all is scored as 0. Talking about the brainstem response, so pupillary and corneal reflex if present, it scores 4. So pupillary reflex दोस्तों are the reflex that we put on the light, torch light, and if both the pupils constrict and dilate, corneal reflex is what we do with the cotton swab. So if both these reflexes are present, we score them 4. If one pupil is wide and fixed, we score them 3. If either one of them, either the pupillary or corneal is absent, we score them 2. And if both are absent, we note down as 1. If there is absent pupillary, corneal and cough reflex, we score them 0. The next is respiration. So यहाँ पे they have given us intubation and not intubation. So first, if you are not intubated and regularly breathing, you are scored as 4. If you are not intubated but are having Cheyne-Stokes breathing, so Cheyne-Stokes breathing are your irregular breathing patterns wherein you have increased breath followed by slowing of breath, and in between there might be no breath at all. So that's scored as 3. If there is intubated and irregular, one fast, one slow, one fast, one slow, then it is scored as 2. If you're ventilated and you're breathing above the ventilator, you're scored 1. And if you're breathing at or below the ventilatory rate, you're scored as 0. So this is a very good scale to look upon and is now widely used. So once we know that the patient is conscious, अब conscious तो है, but the next thing that we need to check whether he is oriented to time, place and person. So in time we ask simple question like what date, which year, what season, what is the time of the day. So all the what questions. In terms of orientation to place, we check whether the patient is oriented, whether he is in a hospital or in a house setting, his current city, state, all the whereabout question. The next thing we assess is the orientation to person, whether he identifies himself with full name, age, occupation, he identifies his family members. So all the who questions. These days, researchers emphasize a lot on orientation to circumstances, which means that we ask questions as what has happened to you, why are you here? We check if the patient is oriented to his condition, about his disabilities. Medically, we document orientation as orientation into 3 if all the 3 are present, into 2 if any 2 of them are present, and 1 if only 1 is present. So you do not actually have to separately check orientation. So the hint to finish it quickly is with your history you will get a lot of these answers. If not, in your GCS, remember during the verbal response, the first one was oriented verbal response. That's when you can question all of these and finish it. So this is very important because, for example, if a person does not identify or does not orientate to his disabilities, or he's not able to identify a family member, all this will definitely indicate a more of perceptual deficit. If he's not able to remember the year grossly or his address, then somewhere we need to dig in for memory issues. So that's why each component of higher mental function is important for us to know.
Hi friends, I hope you understood a little bit about consciousness and orientation. And in our upcoming videos, we will understand some more components like attention, memory and so on. So stay tuned for part 2 which will come very soon. And if you have any doubts in today's lecture, please mention it in the comments section. We will address them. If you liked our today's video, don't forget to like, share and subscribe. And don't forget to hit the bell icon to get future notifications from our channel. Till then, take care and keep learning through Physiogyan. Namaste.